Hi everyone, welcome to this AJR point versus counterpoint video today. I'm Sungmin Woo from Memorial Sloan Kettering, and here with me today is Valeria Panebianco from Sapienza University of Rome. And we are absolutely thrilled to be talking about our point versus counterpoint articles in AJR, dealing with the topic of MRI for biochemical recurrence or biochemical failure in this era of targeted PET tracers. Valeria, it's so nice to see you again, and I am absolutely thrilled to talk about this topic with you.
Hi, I'm Valeria. My pleasure, dear Sungmin. It's very exciting indeed to be part of this discussion on innovative and controversial topic as prostate cancer recurrent disease.
So, Valeria, we've been assigned the point and counterpoint, and we're on totally opposite sides. Myself, the point, saying that MRI is no longer needed, and yourself, the counterpoint, that MRI is still useful and needed. But I think we do agree that it's not a simple yes or no, but it's a rather multifaceted and very complex question to answer. But in the end, we need some sort of imaging or advanced imaging to localize the disease and to use that information to, stratify or triage patient management, right?
Yes, of course, I agree. However, we are not only discussing on advanced imaging, rather on what type of imaging needs to be performed to which category of patients during their workup, therefore on precision diagnostic.
Of course. So why don't we get down to business, and I'll start with the point. So point, MRI is no longer needed. Well, to talk about this, we have to think about the changing landscape of salvage treatment in patients with biochemical recurrence or failure in prostate cancer patients. Now, more and more evidence now supports that earlier salvage treatment when you have biochemical failure is associated with better outcomes. Just for an example, performing empirical salvage radiation to the prostatic fossa, even without visible disease on, let's say, MRI, is not only feasible, but is associated with better biochemical control. And lots of studies have shown that, and it's really pushing the limits for when to perform salvage radiation. At lower PSAs than we would have traditionally done using, for example, the Phoenix criteria and so on. Studies show that, let's say we use PSA less than 0.5, 0.2, 0.1, or even at the earliest point of rise as a indicator to perform salvage radiation. Studies have shown that these are associated with better biochemical control and better intermediate to long-term outcomes. Now, saying that, how does MRI's good diagnostic performance metrics fit into this landscape? Well, the majority of the literature looking at how MRI performs in the setting of biochemical recurrence or failure, if you look at those patients, the PSA values have a very wide range. Just looking at the upper limits, let's say the median values go up to 5.3 and upper limits go up to 68. Now, these sort of high PSA values in patients with biochemical failure would not be acceptable in today's practice, where you would not be withholding salvage radiation until the PSA values reach this number. Then what if we look at the diagnostic performance metrics of multiparametric MRI at low PSA values? Let's say in a study less than 1.0 nanogram per milliliter, the detection rates of pelvic MRI was only 11%. And most of the disease was found mainly in the form of local recurrent disease. Now with that, let's look at PSMA PET. PSMA PET has shown to have better detection rates, and this in turn translates into changes in management. Let's look at some numbers. So PSMA PET can detect recurrent and metastatic disease in patients with biochemical recurrence and failure at low PSA levels, let's say less than 0.5 nanogram per milliliter. About a third of those patients have PSMA-avid disease present. If we look at patients that have negative disease based on conventional imaging, and that includes not only MRI, but also CT and bone scans, about a half of them have some sort of positive disease. And a lot of these are outside of the pelvis. So these type of increased detection rates of PSMA PET will in turn lead to management changes, whether it changes the curative intent to palliative or vice versa, or it could be that we're changing the treatment modality, or even just as little as changing the salvage radiation fields. If we take a look on the right, for example, it's a case of a gentleman with prostate cancer, post-prostatectomy, now with rising PSA at levels of around 0.8. On the top is an MRI, and on the bottom is the fused PSMA PET CT. On MRI, because I'm just showing one slide, we don't see the prostatic fossa, but there was no suspicious findings there. And of course, no enlarged pelvic lymph nodes. However, looking at the white arrow, which is pointing at the small sub-centimeter sized right external iliac lymph node, there is a focal and very avid tracer uptake on the fused PET CT images below. This was suspicious metastasis, so salvage radiation was performed to include this area. Subsequently, PSA levels were undetectable, and so long the patient had durable biochemical control. So in conclusion, in this era where we're striving for earlier salvage treatment, and in those levels of PSA, MRI may not be as sensitive as need to be, but now we have a superior detection rate modality of PSMA PET, which can alter and change our management. So maybe that supports the reason why MRI may no longer be needed. So I'm gonna hand the baton over to you now, Valeria.
Well, the decision between MRI and PET, Sungmin, will reflect patient risk, in my opinion. And indeed, it's not a binary one, as you said earlier. MRI should be recognized as an important early imaging modality for detecting local recurrence of prostate cancer, based on high specificity, ability to inform biopsy targeting, especially after radiation therapy, as you know, and high accessibility. That's why we developed PI-RR scoring, not only to standardize image acquisition, interpretation, and reporting of MRI after radiation therapy and radical prostatectomy, both therapy for curative intent, but also to guide patient management. Note, please, that the majority of recurrence at specific ranges of PSA levels occur locally. Actually, PI-RR was recently validated in a multi-reader study on 100 patients with biochemical recurrence. As you can see, the MRI metrics were high for both patients, undergone 2 radiation therapy and radical prostatectomy, with the median PSA ranges often lower than 1. To be honest, the main limitation of MRI, being at the same time a highly sensitive and specific modality, is a lack of nodal and distant metastasis assessment, except for pelvic structures. I show you a case. In this case here, an example of a true positive MRI and false positive PSA PET CT. Please keep in mind that urinary excretion of these agents can limit assessment of local disease due to confounding activity from the bladder. And this is an example that occur more frequent in different experience. For all these reasons, when proposing individualized pathways based on risk, patients should be ideally stratified in groups and directed, in this case, to 4 different possible pathways. In summary, those who are at low risk of developing the recurrence based on EAU guidelines with a favorable prognostic profile can be evaluated with MRI as first-line study due to the low risk of distant metastasis. On the contrary, patients with an intermediate or high risk of biochemical recurrence with a less favorable prognostic profile based on EAU guidelines should be investigated using PSMA PET-CT. While MRI may still have a key role as an adjunct after initial PET, MRI may in fact be considered as a first-line test in many instances.
Valeria, I think you really nicely laid that out. And whether we use MRI or PET should not be a binary decision, just like you said, and it should be risk stratified based on many factors that we already know. And in the end, I also like the fact that we both showed cases that are quite contrary to each other, showing the strengths of both the PSMA PET and the other one of MRI, also showing the limitations of the other modality. So, like I said, we are still figuring out how and where and when we should use these modalities. And absolutely, it is not a binary decision.
Thank you for your opinion. And to conclude, risk stratified decisions regarding whether to first perform PET or MRI should ideally be performed in the setting of multidisciplinary meetings on a patient-by-patient basis until additional high-quality data are available. Such a decision will remain heavily influenced by issues of accessibility as well as physician and patient preference. Okay, so it was a great pleasure to discuss with you, Sungmin, and I say hello to everyone and thank you for your cooperation.
Pleasure was mine, Valeria. And everyone, thank you for listening.